So with that said, I would like to introduce colleague Rebecca Munich. Becca is with the Ecology Center and with the Great Lakes Lead Elimination Network, and she's going to move us into our next discussion. Becca.
Wonderful. Well, thank you so much for having me, Michelle, and thank you for organizing such an incredible event. I just want to briefly introduce my organization, the Great Lakes Lead Elimination Network, and then get on to the rest of the program because it's very exciting today. So the Ecology Center is a nonprofit advocacy organization based in Michigan, but our work is really spans nationwide. So we're focusing right now on our work on lead, but everything we do is at the connection of human health and the environment. In 2018, we brought together advocates working on lead poisoning prevention at the local level and the state level in Great Lakes states to form the Great Lakes Lead Elimination Network. And we're so happy to be able to help sponsor this event today and work with Women for a Healthy Environment and other partners to bring it on. Lead Safe Cleveland Coalition, for example, is also a member of the Great Lakes Lead Elimination Network. And Dana did chat out information if you'd like to learn more. I'm going to keep it very brief today. But we know that in our states across the Great Lakes, we have a high percentage of pre-1978 housing. We have, unfortunately, disinvestment in our housing infrastructure in many of our states, all for a very long time. We have old water infrastructure in some communities as well, so lots of lead service lines that are being replaced at the moment. And we work together through the Glenn Network with our partners like Women for a Healthy Environment, Lead Safe Cleveland, and many others in each of the 8 Great Lakes states to share best practices and policies on lead poisoning prevention, to share what obstacles we're coming up against in our states and our communities and how we can overcome them, how others in other places have come up with model programs. So if you're interested in learning more about this, do check out the link in the chat and feel free to send me an email. I'm happy to connect with anyone else. But I want to get to the good stuff today. So today's presentation really highlights some of the things that every one of our states in the Great Lakes region is looking at in terms of the new blood lead reference values set by the CDC. We've been talking with our state public health leaders about what those changes mean to them, and if they've already updated the value, if they're working with the new value, or if they're looking to figure out how to do that, how we as advocates can help them. So I'm really excited to hear from Dr. Allwood more about this topic. Dr. Allwood, Paul Allwood, serves as the Chief of Lead Poisoning Prevention and Surveillance Branch within CDC's National Center for Environmental Health, Division of Environmental Health Science and Practice. He directs the scientific and programmatic activities related to childhood lead poisoning prevention throughout the United States. And today, Dr. Allwood is going to talk about the update to the blood lead reference value that the CDC announced a year ago during last year's National Lead Poisoning Prevention Week. With this update, we're getting closer to recognizing that there really is no safe level of lead. We all know that on this Zoom, and encouraging health departments, federal agencies, healthcare providers, and communities to really prioritize prevention of lead poisoning. So thank you so much, Dr. Allwood, for joining us today, and I will turn it over to you.
Good afternoon, everybody, and thanks for that very nice introduction, Rebecca. So as Rebecca said, I am the Chief of the Lead Poisoning Prevention and Surveillance Branch at the CDC. And it's a real pleasure for me to be to be participating in this very, very important summit. And, I was pleased to hear the presentations from the Cleveland Coalition, which, tells me there's a lot going on. And I'm really pleased to hear all of that. So we'll start with just a brief overview of the CDC's lead program. I think some of you may be very well familiar, but others may not be as such. So the CDC has a primary vision of eliminating childhood lead poisoning as a public health problem in the United States. There are four key strategies that we are pursuing in order to get to that vision. And they include identifying high-risk populations, ensuring that we are conducting testing at an appropriate level, ensuring that there is effective follow-up for children that are identified as having lead in their blood. And we are also promoting and pursuing primary prevention through population-based interventions to address lead in the environment. And that work that the Cleveland Coalition is doing, and also others, is very, very reflective of that. And we're really happy to hear about that kind of activity. We're also, we've established cooperative agreements with a number of partners at the state and local level. We currently fund 62 such partnerships. And we're really pleased to say that all but 2 states now have active programs and partnerships with the CDC. And we're currently working to establish working relationships with the only 2 states that we don't currently have an active partnership with. So with that, I'd like to say a little bit more about how we might all understand the blood lead reference value. So the CDC has been defining the criteria for interpreting blood lead levels in children for a long time, for over 40 years. And over that span, there have been different terminology that have been used for describing levels of lead in children's blood. And I won't go through all of the different terminologies, but at some point in time, CDC referred to lead in children's blood at certain levels as undue or increased lead absorption. Then we moved on to elevated blood lead level. And then at some point in time, at certain levels of lead in blood, we developed the terminology level of concern. And that level of concern was used to describe, concentrations of lead in blood at or above 10 micrograms per deciliter up until 2012, at which point the CDC introduced the blood lead reference value. And we discontinued the use of the term level of concern. And that was because, as Rebecca said, and I'm sure all of you on this webinar know about this, there is no safe level of lead in blood. And so instead of a level of concern, because all levels would be of concern, the CDC introduced the blood lead reference value. So what is a blood lead reference value? The blood lead reference value, otherwise referred to as the BLRV, is a statistically derived population-based value, which is used to identify children under 6 who are in the upper end of the blood lead level distribution in the United States. The BLRV is based upon the 97.5 percentile of the blood lead distribution. And that distribution is established from data that's collected by the National Health and Nutrition Examination Survey, or NHANES. In 2012, the BLRV was established at 5 micrograms per deciliter. And again, this was based upon NHANES data, and specifically NHANES data from the 2007 to 2010 cycle. In 2021, almost exactly a year ago, the blood lead reference value was updated and was actually lowered in this instance to 3.5 micrograms per deciliter. And that was based upon reviewing NHANES data from the 2015 to 2018 cycle. And I have to say here that we got here largely as a result of very, very effective work and studies that were conducted by the Lead Exposure Prevention Advisory Committee, which is also known as the LEPAC, which voted unanimously last year that to recommend that the Secretary of HHS and the CDC Director revise the blood lead reference value based upon their review and analysis. So let's just talk a little bit about what the blood lead reference value. Well, so let me just mention a few key points about, lead in blood that everyone should, if you take nothing more from this talk, you should always keep these things in mind. So the first key point is, and it's mentioned all the time, and to some it seems a little incredible, but it is, as far as we know, actual fact that there is no safe level of lead in a child's blood. There's no level that's safe that we know of. We also know that even low levels that have been measured in children's blood can affect learning, the ability to pay attention, can impact overall academic achievement, and perhaps have other neural behavioral effects, and some of which may be irreversible. That's the reason why the CDC's advisory committee, the LEPAC, prior to the LEPAC in 2012, the then advisory committee recommended that we discontinue use of the term level of concern and instead replace that with a reference value. Okay, so what are some of the benefits of the blood lead reference value? Okay, so we know that there has been overall decline in blood lead levels over time. We've studied that very intensively, and we can speak with great confidence that over the last 40 years, there's a pretty steep decline in the average concentration of lead found in children's blood in this country. However, we know that lead exposure remains a significant health concern. And in some cases, depending upon where children live, depending upon their race background, depending upon their poverty to income situation, they may be at very, very high risk for that exposure, as you've heard in one of the previous presentations. So updating the reference value allows the CDC, our federal agency partners, health departments, other public health agencies to make sure that the resources and the attention is being paid to children that are at the highest risk of lead exposure. There are many children in this country that have already been exposed to lead. Current estimates are that there's probably something like 500,000 children that would have blood lead levels that would be at or slightly above the current reference value. And so we need to identify those children, and we need to ensure that as we dedicate resources and take public health actions to try to address this very, very pernicious problem of childhood lead poisoning, that we are targeting those kids that have the higher amounts of lead in their blood. Everyone knows that a primary source of childhood lead exposure in this country is lead-based paint. We are also very well aware, perhaps before, but reinforced as a result of the Flint crisis, that there is a lot of lead in plumbing, and depending upon the water conditions, the chemistry of the water, some of that lead can leach out and be a source of lead exposure to kids and adults as well. There's also lead in soil. There are certain locations around the country where historical uses industrial activity may have led to significant lead contamination of the soil. There's also lead in soil caused by deteriorating exterior paint that has turned into dust and fallen in and around homes, and that could be a source of exposure for children. Children can also be exposed to lead from eating contaminated foods through the use of folk remedies and certain kinds of folk medications. Cultural products have also been linked to childhood lead exposure, and various consumer products have been linked to child lead exposure. Recreational activities is also a source of lead exposure, and in many cases, kids are exposed to lead from parents who take lead home, as a result of their occupation. They get exposed to lead on, during their work, and if proper care and attention isn't paid, then some of that lead can be taken home on clothing or on boots and other types of implements. All right, so let me just take a moment to say what the blood lead reference value is not, because we do get a lot of questions about that, and we recognize that it's not necessarily the most intuitive concept. The blood lead reference value is not a clinical reference level that defines an acceptable range of blood lead levels in children, and it's also not a health-based toxicity threshold. So, it should not be interpreted as a saying, if a child has a level that's above BLRV, then certain kind of actions, must be taken. And if they don't, then certain actions need not be taken. It's ultimately up to the discretion of the medical provider. But just to reinforce the point that the blood lead reference value is not intended as a treatment threshold or a toxicity threshold. BLRV, on the other hand, is a policy tool that helps us identify children who are higher risk of lead exposure compared to most children, so that those children can be prioritized for efforts to link them to care and to provide them with the appropriate supportive services. One thing to note is that the primary difference between a blood lead reference value of 3.5 versus the prior blood lead level, which was 5 micrograms per deciliter, is that now children that fall in between 3.5 and 5 will now be prioritized for follow-up action. There will be notification based upon the updating of a blood lead reference value, and those children that would ordinarily not even necessarily, the parents of those children would not necessarily have even been told that there was a finding of lead in blood, at or above 3.5 to 5 will now be told if a child has a level of say 3.5 or 4 or 4.5 or in that range. Tracking the blood lead reference value, are tracking blood lead levels and comparing them to the population norms can also help communities identify where there is need for special efforts to try to address sources of lead and to carry out primary prevention activities, and can also help to give some idea of how effective primary prevention efforts are. Because if we are effective in preventing children from being exposed to lead in the first place, then we should see lowering of the average blood lead levels. And as I said at the beginning, our goal is to completely eliminate this problem as a public health problem in the United States. Should also say that the blood lead reference value is not a regulatory standard. It's not law. However, and I'll share a little bit more about this, but we do know that it does inspire and promote actions at state and local levels that are very, very consistent with the goals of the CDC to prevent children from being exposed to this terrible hazard. So since we announced the update to blood lead reference value almost exactly a year ago, we've done several things to make people aware of the update. Those things included press releases. We published a policy note in morbidity and mortality weekly reports. We put out social media messages. We developed communication briefs for state and local public health agencies, healthcare providers, laboratories. And since that time, we conducted an assessment. We did a special outreach to see just how well that communication strategy worked. See, who heard about the update, which of our partners at state and local level are, already, fully aware of not only the update to the blood lead reference value, but are, beginning to take actions to implement it. I'm pleased to say that, what we discovered in March of this year was that virtually all of our state and local partners are aware of the blood lead reference value update, and many of our partner organizations, like laboratorians and medical providers, the word got out and people are aware of this change, and we feel very, very pleased about that situation. We're gonna, as we speak, actually, we are continuing our outreach to partner organizations at state and local level to find out a little bit more about, how well the implementation phase is going. We do know, based upon studies that we've conducted, that it can take some time, depending upon the jurisdiction. It takes some time before a particular jurisdiction is able to put in place the necessary, measures to implement an update to the blood lead reference value. But we're going to learn a lot more about where states are in the next several weeks, and we'll be sure to share that information. We're also conducting reviews, special reviews of our surveillance data. CDC receives surveillance data from the states, and we are looking at those data to understand how progress towards implementing the blood lead reference value is going along. Specifically, we're looking to see if labs are reporting blood lead levels, with a decimal, that's between 3.5 and 5. And prior to the update to the blood lead reference value, it was very common for some labs to report a level at 5 micrograms per deciliter, or a level that simply said less than 5. So we're looking at our data to see if that's changing. We're also assessing if children with levels between 3.5 and 5 are getting referrals, are being linked to appropriate care and follow-up services. And we believe that we'll be able to see some evidence of that in the data that's submitted to us on a routine basis. What we're going to do is, we're also, going to be conducting a survey. We do a survey every year, and of all of our funded programs, all the programs that receive funding from the CDC, and there's 62 of them out there. And we're hoping to learn from these programs what blood lead levels trigger follow-up actions based upon their local state legal frameworks and their budgets and resources and other things. So we should get a better picture in a relatively short amount of time of how well things are going with the implementation of the blood lead reference value update. Based upon what we find, we will develop additional outreach materials to promote the updated blood lead reference value. We'll be willing to sit with our partners and discuss what barriers there are and ways in which the CDC might be able to help partners overcome these barriers, and take whatever actions are necessary to continue to promote and encourage broad implementation of the updated blood lead reference value. I have some good news. Since the announcement a year ago, the overall response has been very positive, and we have so far received very few questions. And as I said before, our prior studies indicate that in some cases it could take a while before jurisdictions are able to, move everything in place to adopt. But we have had no jurisdiction, no entity, no agency, no organization has come out to my knowledge and said, this update was necessary. I think that's a very, positive thing. And, we are having communications with our partners at the state and local level on a routine basis. Our project officers are, available and willing to have discussions about, what barriers or what challenges jurisdictions are facing. But so far the response has been very, very positive. We are also seeing some important changes in policies that will support broad implementation of the BLRV. One example of that is that this summer, the Council of State and Territorial Epidemiologists, which is a key CDC partner for surveillance, updated its position statement on blood lead testing, and now refers to the condition on the surveillance as lead in blood. And prior to this update of its position statement, CST was defining the condition on the surveillance as elevated blood lead level. But again, keeping in mind that since there is no safe level of lead in blood, the CDC does no longer uses the term elevated blood lead level, and instead we encourage people to refer to levels of lead in relation to the blood lead reference value. More good news as of now, as of today, we know that there are 21 states that have already implemented the new blood lead reference value, and that there are 14 states that are in various stages of adopting. And there are several other states that are doing things like beginning to look at their feasibility of implementing the reference value, and we're standing ready to assist as requested with the efforts of those remaining states. Our future plans are, as I said, we are going to gather all the data from our various conversations with our state partners and partners in labs and other key stakeholders, and then we'll develop as needed additional guidance, additional communication devices, and we'll continue to do evaluation into the future to ensure that we know and understand how progress is taking place across the country, and most importantly, what are the barriers and what are some possible ways to overcome these barriers. So just to wrap up and just to kind of summarize what I believe are sort of key takeaways. First, the overall implementation of the update to the blood lead reference value has been a success, but we know there's still a lot of work to do to protect children that are at risk for exposure and to ensure that we achieve health equity. Updating the blood lead reference value will allow CDC, federal partners, and health departments to focus resources and on the children with higher levels of lead in their blood compared to most other children. And then finally, updating the reference value also supports CDC's and the administration's commitment to health equity and to addressing environmental justice. Because there's still significant disparities in exposure and health outcomes across racial, ethnic, and socioeconomic status. And this is, particularly true with respect to lead exposure, and this is something that we are determined to address. Thank you so much for allowing me to speak, and I'm not sure if we have time for any questions, but I'll turn it back over to the moderator.
Thank you so much for joining us today. We do have a couple quick questions in the chat. We'll just try to address them real fast. The first is, do you think that the CDC will be reevaluating the blood lead reference value in several years?
Yes, this is part of our commitment that, on an ongoing basis, we'll review the NHANES data And based upon that type of review, it will determine, how we will adjust the reference value. Because again, it is based upon the 97.5% of the distribution as determined by NE.
Yeah.
We will not revise upwards. I mean, obviously, it will not, go back in that direction, but depending upon how trends in blood lead levels go, in the future, I expect that we will be revising.
Awesome. Another one we just got was, would the CDC recommend home investigations when a child has a level of 3.5?
Yes, I think, we and the CDC has put out guidance, and I would encourage everybody, to go to our website and look at our guidance for recommended actions at different blood lead levels. And, the guidance will indicate, it is ultimately a factor of resources and perhaps, local laws and regulatory framework. But it is the CDC's recommendation that follow-up actions be taken at 3.5.
And then the last one, do you find that pediatricians are familiar with the update and are communicating the importance of screening and lead prevention to families when doing lead tests?
Yes, this is a good question. And, our indications are that, a lot of pediatricians are aware. Not sure I can speak for every single one, but we are continuing to find ways to engage with that very, very important constituency. And an example of that is that this summer, CDC put out an article in the AAP News, which is an online journal that reaches a large number of pediatricians, indicating, reminding everybody about the blood lead level, the blood lead reference value update, and also, reminding pediatricians that we have been seeing a drop off in rates of blood lead testing, and encouraging them to, be advocates and champions for increased blood lead testing.
Awesome. Well, thank you so much for joining us today. We are honored that you were able to come. So thank you so much.
Thank you. It's my pleasure.